I'm from both QIMR and the Royal Brisbane Hospital, and I'm a transplant physician at the hospital. And my area of interest is in allogeneic stem cell transplantation and graft-versus-host disease in particular, and sort of the immune mechanisms of how that type of transplant eradicates leukemia. So I'm just going to walk through some of the issues relating different types of transplantation, some of the complications of each. And transplantation is from a allogeneic transplantation is done for leukemia, which always surprises me is actually not. Hematological malignancies are actually relatively common. 1 in 13 of us will develop a hematological malignancy, and 1 in 10 of us will die from a hematological malignancy. So it's actually quite a common disease, much more common than we think. And we think about transplantation because leukemia outcomes with chemotherapy alone are generally not as good as for transplant, and so we can tend to sort of double survival rates with transplantation. So when we undertake transplantation or stem cell transplantation, it was originally undertaken under this principle that if you can give increasing doses of chemotherapy and radiation, that you can eventually get to a stage where you can kill all the cancer, and then you can. So the problem is that as you escalate the doses of chemotherapy and radiation, you get to a point where not only you kill a lot of the leukemia or lymphoma, but you also kill all the bone marrow because it's the most sensitive organ from a chemotherapy point of view. And so transplantation grew out of this idea that, well, what if we give chemotherapy doses that are higher than we can normally give, and we could go over this threshold and eradicate all the bone marrow, and then just transplant in stem cells after we're given the chemotherapy, and that should allow us to escalate the doses of chemotherapy and improve the cure rate of the transplant. What that does is sort of potentially allow us to get to sort of curative levels of radiation and chemotherapy, and then to put back in normal stem cells that have been either frozen, if they're from yourself, or from another donor who has the same tissue type. When we do that, when we do put in stem cells back in afterwards, the stem cells can either come from the bone marrow, or more usually now, in fact almost always now, they come from the peripheral blood, where the donor is given GCSF or Neupogen or Neulasta, and the stem cells are collected from the blood, and then they transfuse back through a Hickman catheter. When we collect stem cells like that, we also collect the immune system cells, and so not only are we replacing the blood system, we're replacing the immune system when we do this procedure. And so there are different types of transplants that have different problems and different benefits. So if we use a donor that is yourself, in other words, you take the stem cells out when you're in remission, they're frozen down, and then they're given back to you after high doses of chemotherapy. That's called an autologous transplant. Autologous because they're your own cells. That's a treatment that's predominantly undertaken for myeloma or non-Hodgkin's lymphoma or Hodgkin's lymphoma. So that's an autologous transplant procedure, and the cells are all your own. Very unusual type of transplant is if you have an identical twin, and then the cells come from your twin, but they're essentially the same immune system as you because they're identical. I think we can forget that. Not many of us have identical twins. The alternative is that they come from a family member or an unrelated donor that happens to have the same tissue type as you, and they're harvested in a steady state, and that patient will be otherwise matched to you, and so that's an allogeneic transplant, and that's where a lot of what I'm going to talk about is about when we're using allogeneic cells that seem to be matched, and that we do this type of transplant mainly for leukemias and sometimes for lymphoma and myeloma that's resistant or relapsed after a transplant from yourself. And so there are two types of donor, two ways, as I alluded to, of getting cells from the donor. One is by taking the donor to theatre, putting them on their stomach and harvesting bone marrow out of the back of the pelvic bones. But more usually, the donor now has GCSF, Neupogen, and we take the cells out of the peripheral blood. Autologous if they're your own, allogeneic if they're from someone else. The problems with an autologous transplant as opposed to an allogeneic transplant, the first issue is that the stem cell graft can be contaminated if it's an autologous transplant with the original tumour. The real outcome of that, or whether that's important, is not really clear. But the procedure, as I mentioned, is usually used to treat myeloma and non-Hodgkin's lymphoma and Hodgkin's, and it's a pretty safe procedure. The chances of anyone coming to grief and dying from an autologous transplant these days is less than 2%. So it's a procedure that you're in hospital for 2 to 3 weeks. It's not particularly pleasant, but the chances of you coming to grief in that procedure are very low. An allogeneic transplant, the advantage is that cells are coming from a normal donor, so there's no chance that they're contaminated with any tumour or malignancy, but it does introduce a new immune system. And that's the issue with this type of transplant. It's the benefit and the problem. It's a much more complicated procedure than this. You're usually in hospital for about 5 weeks. There is a transplant-related mortality of about 15 to 20% these days. If it's a very high-risk procedure, it can be higher, but it's the general chance of you dying during the transplant procedure here is about 15 to 20%. It's really only undertaken in a few centres. There's about 6 centres in Australia, and all the transplants, this type of transplant, in Queensland and northern New South Wales are done at the Royal Brisbane Hospital. And Royal Brisbane does a lot. It's the largest transplant centre in the country. We do about 120 a year. And it's usually used to treat leukemia and younger patients and myelodysplasia. I define young now as sort of 60, but we do these type of transplants now up to, in people in their 60s commonly, and sort of up to 70. So young is relative as I've got older. So bone marrow stem cell transplantation. So we put in a new clean, manipulated and disease-free blood system and immune system. And the major complication is a process called graft-versus-host disease. So if you think about a kidney transplant, if I put a kidney into you, your immune system can see my kidney as foreign and reject it. Here, I'm going to put my stem cells and my immune system into you. And even though that we think that we're the same tissue type, there's always small differences between my immune system and your immune system. And my immune system can see that you're not me and try and reject you. So obviously, it's that when that occurs, and it occurs to some degree quite commonly, it's a much more dramatic process, because you have my immune system mounting a rejection response against all of your tissues. And that's this process called graft-versus-host disease. The graft is my stem cell graft, my immune system, and my immune system. You're the host, and I'm trying to mount a rejection response against you. And so this is our main difference between and complication in an allogeneic transplant versus an autologous transplant. And it occurs in about half to 3/4 of patients to some degree. And it primarily targets early on of the skin, liver and gut. And it can cause a rash. This is the sort of common rash you see. When it attacks the gut, it can damage the lining of the bowel and cause diarrhea. So diarrhea is one of the symptoms, and it can also attack the liver and cause a type of hepatitis. And so, from a patient point of view, we look for rashes, diarrhea, and jaundice in patients when they're having an allogeneic transplant. Later on, this is called acute graft-versus-host disease. It occurs in the first 100 days. Later on, there can be a process called chronic graft-versus-host disease, which occurs after 100 days, usually sort of 4 to 6 months after transplant. And it can make the mouth dry and it can make the eyes dry. And so the cardinal features later of graft-versus-host disease after a transplant are dry eyes, dry mouth, a skin rash, and it can affect the liver as well. But the skin rash looks a little different. And the risk factors for getting graft-versus-host disease after transplant are how old you are and how old the donor is, whether you are the same tissue type. So we always try and look for exactly the same tissue type. We talk about 10 different loci for tissue type, and we try and match all 10 of those. Sometimes we can't, and we talk about a 9 on 10 transplant. And if you're not completely matched, then your chances of getting graft-versus-host disease is higher. If the donor is unrelated versus a family member, then there is a higher risk of graft-versus-host disease. There's about a 1 in 4 chance of any of your brothers or sisters having the same tissue type matching you, not about exactly 1 in 4. And if one of the brothers or sisters doesn't match, if you're Caucasian, there's about a 70% chance of a donor on one of the international panels matching you. There's about 16 million people tissue typed around the world. So if you're of European descent, you have a high chance of finding an unrelated donor of the same tissue type. There's a few other things that increase your chances of getting graft-versus-host disease. If you're male and the donor is female, particularly if that donor's had pregnancies or the donor's been transfused before, those increase your chances. And there's one of the herpes viruses called Cytomegalovirus that about half of us have had, usually in our youth, and it lies dormant in our systems until we get very immune suppressed, and transplantation is one of the most immune suppressing procedures, and that virus can reactivate after transplant, and that can be associated with more graft-versus-host disease as well. But main things that make a difference are whether the donor's matched or not, and your age. When I talk about being old for a transplant, the age that matters, and that you're likely to get more complications if you're over this age, is about 30. So it doesn't, whether you're 60 or 50 or even 40 doesn't matter that much. It's whether you're young as defined by, a teenager or in your 20s, you're likely to have less problems than older than past that. So for most of us, age is relative. So why do we do an allogeneic transplant if it's associated with all this graft-versus-host disease and all these complications? And so the reason we do it is because this immune reaction, where the immune system of the donor mounts this rejection response, it also mounts a rejection response against any residual leukemia. And that's called a graft versus leukemia effect. And that is the main way that this type of transplant cures patients, and that there's an immune-mediated effect against residual leukemia that eradicates the leukemia. And so most of the curative effect of this type of transplant is not via chemotherapy and radiation, it's by this immune-mediated graft versus leukemia effect. And it's a rejection process against the leukemia because the leukemia is also foreign. The process is associated to some degree with graft-versus-host disease. And there's this, patients always say, I need a little bit of graft-versus-host disease, and this is why, because this anti-leukemic effect is associated with it. And it is true that the best overall survival is in patients with a little bit of graft-versus-host disease. But you don't want a lot. And so patients get very worried about not having had bad graft-versus-host disease, but actually patients that get bad graft-versus-host disease do the worst. And so Please don't think that if you're a patient and you're going through this transplant, you need to get graft-versus-host disease and bad graft-versus-host disease, because you tend to do worse if you do. So you want a little bit of graft-versus-host disease, but people that do the best have a tiny bit, then the next group have none, and then the group that get bad graft-versus-host disease do the worst. So it's all relative. A little bit is good, a lot is bad. We talked about skin. So how do we grade graft-versus-host disease based on how much of the skin it affects? It usually starts in Queenslanders who have had a lot of sun-damaged skin. It usually starts around the nape of the neck, where there's been a lot of sun damage, and in the palms of the hands and the soles of the feet. So if you're having a transplant, we'll also always ask to see your hands and your feet, and that's why, because it tends to be an area that we see graft-versus-host disease in first, and it can become quite widespread and severe, and it can actually progress to a stage where the skin starts to peel off like bad sunburn. And this is the sort of what's called a maculopapular rash that can progress to involve most of the skin. But the question is, how do we know if you've got diarrhea that it's graft-versus-host disease? Yeah. So there are a couple of things post-transplant that cause diarrhea and one of them is graft-versus-host disease. The other is that virus that reactivates CMV can cause a type of colitis. Some of our antibiotics can cause diarrhea, and some bugs can cause diarrhea as well. So what will tend to happen is if you come into hospital and you have diarrhea, we'll do a culture of the stool to see if there's any bugs or viruses. We'll do a blood test to see if that virus is reactivated, and then we will do some endoscopy, so a gastroscopy and a sigmoidoscopy, which is basically using a flexible telescope type machine to look at the bowel and look in the stomach, and to take some biopsies, and there's some very obvious features when we look down the microscope at biopsies that tell us it's graft-versus-host disease. So that's the procedure that goes through. We assume everything. The rule is that if you have diarrhea, we assume it's graft-versus-host disease until we prove it's not. So if you come in with diarrhea, we will usually treat you as graft-versus-host disease while we're trying to do the other things to make sure that it is. It's easier to treat early and bail out than to wait and not treat early. So we talk about staging for skin, so you can see that if you have a rash over half your body, or you have 1,200 mils of diarrhea a day, you would be stage 2 for each organ, and then you're graded. And this is the real crux of the matter, how you're graded, how your GVHD is graded. And you can see that when I said that we want a little bit of GVHD, which means mild, which is grade 1, which means you have a little bit of skin GVHD, but that's all. Once you get up to past grade 2, so grade 2 GVHD means you can have quite a significant skin rash. You're a tiny bit jaundiced, or you have a diarrhea of sort of 600 mils a day. That gives you grade 2 GVHD. And then 3 and 4 we tend to think of as the same. That grade 3 and 4 is severe graft-versus-host disease. And you can see that to have 3 or 4 GVHD, you need to have skin that's starting to blister, or you have to be quite jaundiced or have quite large volumes of diarrhea a day, over a litre a day, and then you're in the severe group. And so we treat anything beyond grade 1, so grade 2, 3 or 4 GVHD means you start treatment for graft-versus-host disease. So when we do the transplant, we try and prevent you getting graft-versus-host disease. And the way that and that's called prophylaxis. Prophylaxis just means prevention. And the way we do that is that you can be treated with an antibody preparation that depletes T cells. And the T cells are the type of white cell in the stem cell graft that causes graft-versus-host disease. That's not undertaken terribly much in Australia. It's used a lot in Europe. It's not really undertaken in Australia. And so if you're having a transplant here, you're not likely to be getting ATG, certainly in Brisbane. But it's one way that we can limit GVHD. It depletes the T cells, which are important in graft-versus-host disease, but they're also important in the anti-leukemic effect. And so you tend to reduce graft-versus-host disease, but also have some effect on leukemia. So we don't tend to do that. What we do is the day before the stem cells are due to go in. So for most purposes, if you're having a transplant in Brisbane, you will have either 3 days of total body irradiation and 2 days of chemotherapy, or you'll have 6 days of chemotherapy. 5 days will be of a drug called fludarabine, and the next day will be a drug called melphalan. We call that Flumel, and the other one's Cytomegalovirus. And if you're younger, we will usually, certainly under 50, we will usually use TBI. If you're older, or the disease we think is not particularly virulent, then it will be this conditioning called Flumel. So those will go for 5 to 6 days. You'll have a rest day the next day, and you will start a drug called Cyclosporine on that day. Cyclosporine is an immune suppressive drug, and it's to try and prevent graft-versus-host disease. And it will start through the drip as an infusion, and it will continue on post-transplant. And it's not so much to suppress your immune system, it's to suppress the immune system, the new immune system that we're about to put into you. So its job is to try and limit the amount of graft-versus-host disease that you get. The side effects of this, it can cause a tremor, it can cause headaches, and it can upset your kidneys. It causes commonly high blood pressure. It's pretty usual for you have to be on some blood pressure medications in the transplant setting because of this drug, which can cause high blood pressure. It can interact with some agents, but the main side effects you'll see we worry about is upsetting your kidneys and high blood pressure. So that starts through the drip, and once your counts start to come back after the transplant, you would go on this tablet orally, and you will usually be on this for 6 months to up to years. So this would be a long time, relatively long-term medication. Tacrolimus, its other name is Prograf or FK506, is a alternative drug. It's basically the same family of drug as cyclosporine. It has a slightly different side effect profile, and it may be a little bit more potent. And so sometimes we will swap from cyclosporine to this drug tacrolimus because the cyclosporines upset the liver or cause some other side effect, and we'll swap to tacrolimus instead. They're really a very similar drug, and so we don't tend to distinguish a great deal between them. You'll usually get some very small doses of a drug called methotrexate post-transplant. You'll get 1 on the first day after transplant, and then 1 on day 3, 6, and 11. And this just works to try and kill any T cells in the graft that have been transplanted that are trying to react against you. So that's a drug that doesn't cause a lot of side effects because the doses are small. But you will usually have immune suppression after transplant that's cyclosporine and methotrexate, and this will be just 4 doses. Mycophenolate or Cellcept is a drug that is sometimes used in addition to those other 2, or for people that don't tolerate methotrexate. And again, it's used as a prevention drug early post-transplant, and sometimes as a treatment drug if you develop graft-versus-host disease while you're on the cyclosporine. We talked a little bit about this. How do we know it's GVHD? We talked about the gut because it can be other things. For the rash, sometimes drug rashes and radiation toxicity can look a bit like a GVHD rash. Again, a biopsy will easily distinguish usually between drug and GVHD, and the biopsies are usually almost always necessary for gut graft-versus-host disease. Liver function changes, again, can be a lot of different things. It's unusual for us to biopsy a liver because it's harder to get to, and we'll usually biopsy the bowel or the skin. It's much easier and much less invasive. So this was for me to talk to you about anyone who is coming up to transplant in the near future at the Royal, because we have a trial going now. What it is an antibody that blocks a protein called interleukin-6 or IL-6, given on a day immediately prior to transplant. And it's in addition to the usual cyclosporine and methotrexate that I talked about. Now, we've done a trial of 50 patients using this agent at the Royal, which finished at the end of last year, and it looks very good in that we reduced our GVHD rates over historical control by about 70%. And so we're now doing a randomized study. So if you're coming to transplant and you're getting TBI or fludarabine and melphalan, and you have a fully matched donor, you will be offered this study, and the study is now whether you will get this drug or not, and it's a randomized study. So you will, if you agreed to go on the study, you won't know whether you get the drug or not, and neither will we. It's completely randomized. The only people that know are the pharmacists and the people that are decoding the study, and it gets decoded at the end. It's the only way that we can make sure that something truly works without all the bias of doctors and everything else knowing. So it's the final step for this agent. So the other name for this is tocilizumab or TCZ, and so you may hear, if you're coming to transplant, that you'll get asked if you would like to go into that study, and that's the basis of it. If you're having a transplant that's mismatched and that there is an earlier phase study that you will be offered that is the same drug, that is not a randomized study, that is an unblinded study, so you would be asked if you would like to go on that study, you will get the drug, and we will see if it works down the track, because we don't have the same experience in mismatched donor transplant setting as we do with this in the transplant setting. So if the donor is fully matched, we're at the stage where we need to prove finally that it definitely works in a completely blinded fashion. In the mismatched donor setting, we're looking to see if it has any hint of effect, and so it's an earlier study. You would know that you got the drug. I just mention that because anyone who's coming to transplant is going to run into that at the Royal. If you don't wish to go on any of those studies, there's another study at the Royal. We try to have most patients on a study now because it helps us to improve treatment, and that's a good example of how it has, where we just collect a little bit of extra blood at each time and measure some of the proteins and immune cells post-transplant, so we can try and predict graft-versus-host disease for subsequent people. So that's just an observational study. It's called the R17 study. R17 is another protein which we think is involved in chronic graft-versus-host disease, but it doesn't require any different. The treatment's exactly the same. It just means that we take a little bit extra blood from you and measure some of the immune cells and proteins in the blood. So if you're coming to transplant, it's likely that you will be offered one or other. You will be offered one or other study to go on. So I think that's a good thing. It means the transplant unit is doing a lot of research and is trying to improve outcomes, just to prepare. Okay, so what happens if you have a transplant, you get cyclosporine, you get methotrexate, and you get a rash, or you get diarrhea, and you've developed graft-versus-host disease after transplant? And again, it's slightly more likely that you will than you won't. It's about a 50% chance that you will get graft-versus-host disease that needs some treatment. So the first line treatment is steroids, and it's usually prednisone, or if it's through the drip, methylprednisolone. And it is given at relatively high doses. So for those of you who have been on prednisone before, it's given at a dose of 2 milligrams a kilogram. So it'll be between 100 and 200 milligrams a day. usually for 2 weeks, and then as you respond, the dose is tailed off over about 6 to 8 weeks. About half of people will have a complete response to prednisone. So remember, only half of people will get graft-versus-host disease. Most of the people that do will, or the majority, half will respond to steroids, and the graft-versus-host disease will go away, and we'll tail it off, and that'll be that. Steroid refractory graft-versus-host disease is when the graft-versus-host disease doesn't respond to the prednisone. It's the GVHD that tends to put you in that poor prognostic group, because you've got GVHD and it's significant and it's not responding to standard therapy. It's not a death sentence, and that about half patients are now recover from GVHD, but it does mean you're in a difficult group. And we use an antibody to T cells, the ATG, to actually kill the T cells in the transplant, to try, and a drug called Enbrel to try and treat the graft-versus-host disease in that situation. About half of people respond. So you'll see that I said about half of people will get graft-versus-host disease, half of them will respond to steroids, and that leaves about a quarter will get significant to severe graft-versus-host disease. It doesn't respond, and about half of those we can treat, and the remainder is about 15% overall. That you can see is that transplant-related mortality that I talked about. So the acute the rash when it's early post-transplant will go, and so what tends to happen is this will fade, and it goes away, and that's that. This graft-versus-host disease, the more chronic form, can leave scars, and as it has here. That happens later. Yeah, yes, it can. But the earlier graft-versus-host disease in the first sort of couple of months tends to flare up, be red and inflamed, and go. The other things that we will do if you get graft-versus-host disease is that you'll often get steroid creams to put on skin. And if it's just mild graft-versus-host disease, the treatment's often just a steroid cream. You don't. And there's another drug called ursofolk, or ursodeoxycholic acid, which is something that works by making the bile more slippery, and that tends to help the liver function, and you're often on that post-transplant anyway, so that's something that you may well find yourself on. We tend to use it a lot because it's relatively innocuous, and it does seem to help from a liver point of view. The main issue is if you get significant gut graft-versus-host disease, significant diarrhea, anything that you eat can go straight through you in sort of 20 to 30 minutes, and so you tend not to be able to eat, and we have to feed you via the drip with total parenteral nutrition. And so you can see from what I'm saying is what we really try to avoid is gut graft-versus-host disease. Chronic graft-versus-host disease will occur to some people, and most people to some extent. It's usually mild, and it will resolve quickly with steroids. But in about 20% of people, it can be significant, as I just showed you those pictures of, and can cause problems. People with bad chronic graft-versus-host disease, again, that's around 20% of people, tend to not be able to fight infections very well. And if they do come to grief, they tend to do it from infection, not from the graft-versus-host disease. And so the way we define chronic graft-versus-host disease is either that you have localized skin involvement. That means usually a patch of almost like dermatitis, just a patch of like atopic dermatitis that tends to be occasional patches. That your liver function's a little bit abnormal on blood tests is mild graft-versus-host disease. If it becomes more, the skin involvement becomes more diffuse, or you have more significant liver involvement, or you have dry eyes and dry mouth, then that is called extensive graft-versus-host disease. The real problems that people with chronic graft-versus-host disease get that find troublesome are if they have very dry eyes and they have to have a lot of eye drops to keep their eyes moist, or they get significant skin involvement. Those are the two things that people find troublesome from a quality of life point of view. And the treatment for chronic graft-versus-host disease is again prednisone but lower doses, and you tend to be on medications to try and prevent you get infections along the way. And there are a whole lot of new therapies now coming on stream for chronic graft-versus-host disease. So I'm quite hopeful that we're going to have good treatments for chronic graft-versus-host disease in the next 5 years. And I think we're already making pretty good strides with acute graft-versus-host disease, as I mentioned, with some of the therapies at the Royal. And I'm just going to finish with something that we're now starting to look at the Royal, which is this issue of how do you undo cell therapy, or how do you undo transplantation? Because the problem with a transplant or with any form of cell therapy is that the cells are not metabolized or excreted in the liver like a drug. So it's not like you can't just wait for it to get out of your system like a drug, and the cells persist and they expand, and so unwanted effects can persist over time. And so what we are trying to do now at QIMR and the Royal is try and introduce a delete sort of system into the cells so we can get rid of them if they cause problems. And in the first instance, this trial is just opening at the Royal, where we're now going to transplant people who don't have a donor, who have and do something called a haploidentical transplant, where we use a mother or a father or a sibling who's not matched but is half matched, and we take all the T cells out of the graft, which historically leaves a problem with infection and relapse. But we now have a system where we can genetically modify the T cells from the donor in the laboratory and introduce a synthetic, basically a synthetic molecule that will bind to a drug that has been designed so that it causes these two molecules that we introduce into the cell to dimerize, and this triggers the cell to die. And it's called a suicide gene. And one of the scientists at QIMR has generated this technology in the US and brought it back. And so what that does is is that if patients develop, we put low numbers of these cells into patients after this particular type of transplant, and if they develop graft-versus-host disease and these cells expand, we can deliver a drug that doesn't have any side effects other than that it causes the linkage of those two artificial ligands in the cell, and the cell dies. So that was all I had to say. All right. Thank you.